as Ciara said, my background is that I was trained almost entirely here in Belfast. I got my CCT, or Certificate of Completion of Training, in January 2013, so not that much of a too distant past. I was fortunate enough to be involved with the Association of Surgeons in Training. It kind of happened almost by accident, but I quickly sort of fell into that role. It was part of the ASiT executive over a period from 2005 to 2010. What was interesting is that it gave me opportunities to get involved in things that I had previously had no interest in, including the medical political side, and actually ended up on the BMA Junior Doctors Committee as well, trying to argue the case of surgical trainees to try and get benefit for us. It also gave me an opportunity to expand things, and one of the things Ciara hasn't mentioned yet is about the Foundation Skills in Surgery course, which is running in January, is that right? Yeah, right. And other courses established through ASiT, and I was actually the first person to put together the Foundation Skills in Surgery course, and I'm amazed that it's still running, and has actually not only run but also been incredibly successful and being run internationally as well as locally, and I really encourage people to try and undertake that, either as a teacher or as a participant, depending on what your level of training is. I was also elected as the affiliate representative to the Vascular Society Council here in the UK, so I was the trainee representative as part of the presenting team getting the new vascular specialty up and running here in the UK. So you'd read all of that and think that, well, I'm pretty committed to establishing practice in the UK, and that's exactly what I was trying to do. I was trying to make things better here all the time as best we could to try and improve conditions for surgical trainees. As part of my training programme, I took a year of out-of-programme training at the Royal Adelaide Hospital in Adelaide, South Australia in 2012. So that was essentially my final year of training. And I'd also organised to set up a post-CCT fellowship at Flinders Medical Centre in 2013. So what I'll try and quickly go over through the course of the next 80 slides is what were my reasons for going, what can be gained from it, what is the work like out there, and how are the jobs structured, and what are the structure of hospitals, because they are quite different to the structure of hospitals here. What is life like, and what can life offer you out there, and how do you get there, and at what stage? So obviously there are various reasons why people decide to go to Australia, and those can be broadly broken down into the personal and professional. And no one trumps the other, but the majority of people would like to think that they're going for professional reasons, to learn new techniques, increase their exposure, and expand their logbook because of the way that the systems work out there. It does act as a finishing school for those people towards the end of their training, because you do have increased responsibility as a fellow, and it is a very good stepping stone to a consultant system. More importantly, it gives you an opportunity to experience how a different system can work. No system in the world is perfect, and anything that we can learn, that we can take away from any of our systems to try and improve the other, is a really useful thing to learn, even if the new techniques are nothing out of the ordinary. Going across to the other side of the world does pose its challenges, and it does lead to a lot of self-development. And it gives you time out of the rat race here as well to really think about what you want and what is important to you. So it does provide those personal challenges, and it gives you an exciting opportunity, and it gives you an opportunity to go to somewhere that looks a bit prettier than what it does here at this moment in time. I actually went across to Australia at the end of my houseman's year, so I was back in the stages whenever it was a JHO year. So I went across as a first year SHO. I suppose the equivalent to that would be I went across at the end of my F2 year now, and I spent a year working in country Queensland at a place called Bundaberg, which whenever I was offered the job I'd heard absolutely nothing about. The internet wasn't really up and going at that stage, so I had to walk to the local Waterstones to find a tourist guide to see what I could find out about Bundaberg, to find out if I was going to take a job there. And that's literally how I made my decisions, was looking at the Lonely Planet. It gave me an opportunity to sample what life could be like in Australia and what the healthcare systems were like, and that's really led me to where I am now. So what can we actually gain from this? And going across at our stage of life, you know, as mature students who've been through university often will have been through a significant amount of our training. It gives you an opportunity to experience a different culture and lifestyle and form new friends. And forming new friends whenever you've already had your long held and long established friends is actually quite a challenge. And it's something that whenever you're working hard actually tests you in terms of what you can do. There is the professional aspect of consolidating what you've already done and learned, but also increasing your independence and increasing your ability to manage complex systems and problems. You're blissfully free from the politics that go on here. And unfortunately, that is a way of life that junior doctors often do get involved in the politics. And rosters and rotas are never far from your thoughts whenever you're working here on a day-to-day basis. So working in Australia does give you some freedom from that. It does also give the opportunity to work hours. Now that may sound like a bad thing to some people, but actually whenever you're approaching the end of your training, you will be really grateful for how much exposure that you've got by working in Australia. So what is the work like? And I guess this depends on the role, whether you're going across at a fairly junior level as a resident medical officer or RMO, or whether you're going as a fellow or even as a consultant. Make no doubt, the jobs in Australia are busy jobs, and there's reasons for that. But they are immensely satisfying. You feel that you're able to manage patients as best you possibly can, and they do provide you with certain unique challenges that you have to overcome in order to be able to provide that care. I'll talk a little bit about my job in Flinders Medical Centre in South Australia, and I thought it's worthwhile just putting up a comparison of where I've trained and where I'm currently working. And you can see that population-wise, we're not that different. Number of vascular units, not that different. What is interesting is that there is about 45% of South Australians that have some form of private health care. Now that doesn't mean that 45% of patients will see everybody privately. Some people only get cover for their inpatient hospital stays, but it does have an impact on how the health service subsequently works, because the health service recoups money from the private health companies, even if they're managed in public hospitals. Our unit in South Australia also serves a bit of South Australia, Victoria, New South Wales, and also the Northern Territory. So whenever I talked about the public versus private systems, there is a degree of natural selection in this, because the reason that such a high proportion of people have private health insurance is that there are tax breaks for having it if you earn over a certain income threshold. So it actually encourages people to have a private health policy. What that means is that patients then who have private health insurance use the private health system while still providing some funding for the public health system. So the public health system can still run pretty efficiently and provide a good standard of service to those patients who don't have private health insurance. Unfortunately, those patients who can afford private health insurance also tend to be the patients who have a bit of money and who generally tend to look after themselves a bit better. So you end up with this natural selection where the well patients, or the relatively well patients, end up in the private health system, and you end up with the sickest patients in the public health sector. So you end up with this unselected sort of group of patients that you look at and go, oh my God, where have you come from? They are just absolutely crap patients, and worse than anything that I've seen here in Northern Ireland. What's also interesting is that the concept of training also exists in the private sector, and the private sector will support training, and a lot of training will be delivered within the private healthcare system. There are certain barriers in terms of medical records for patients, because sometimes patients will turn up to you without anything other than a GP letter with fairly scant information, because all of their care has been with private physicians. And medical imaging is largely private based in most Australian states, so actually you have to start fishing around various private medical imaging companies to try and find scans, etc. that have been done. Where I work at Flinders Medical Centre, we have 593 beds, so it's a reasonable sized hospital. The unit I work in has a specialist interest in complex peripheral vascular disease and complex aortic disease. We're now made up of 5 consultants, which is only really developed in the past year. 2 registrars, a fellow, a research fellow, and we work alongside 3 interventional radiologists. Our unit is headed up by Professor Ian Spark, and you'll see that he was trained in the UK in Leeds, and spent a period of time as a fellow in Australia, came back, worked as a consultant in Leeds for 7 years, and then came back out to Australia, seeking to provide himself with new challenges, taking up an academic role within Flinders University. Phil Puckridge is a great colleague of ours who's Australian trained, born and bred. Yuto Wong, again, was another UK trained surgeon who worked as a period of time as a consultant here in the UK before going back out to Flinders. And Nadia Blessed, again, is another Australian trained surgeon. And then there's myself in there. So we have a good mix of people who've grown up in different cultures, and that actually has helped us evolve the unit in different ways, because we actually have different people with different interests, different perspectives on things, driving our unit forward. Flinders Medical Centre also provides the overwhelming majority of the rest of the surgical specialties. So it does have the capacity to manage everything that does come through the door. The only thing really missing is MaxFax. The hospital has a helipad, which you'll see why that becomes necessary in my next couple of slides. A fully equipped ED and full radiology facilities. So it is a fully functional tertiary referral hospital. When you look at Flinders Medical Centre and where we're positioned on the right hand side, just to the southern aspect, just at the edge of the upper edge of the blue zone that you can see up there. And that's really Adelaide spread along quite a length of shoreline, because Adelaide is constrained by the beach on one side and by the hills on another, so it spreads north and south. On the larger diagram on the right is technically what our catchment area is shaded in grey, and we cover Kangaroo Island, we cover right down to the southern aspect of the state of Mount Gambier at the Victorian border. But the reality is we also cover other areas within Australia. So we cover patients from Mildura and Broken Hill, which are New South Wales and Victoria country areas. We cover patients from Alice Springs. In fact, just before I came away, I took a patient down from Alice Springs. And we also provide services for Darwin. So in UK terms, whenever you look at the real size map superimposed, you can see why the services in Australia become slightly challenged. You have the grey circles at Darwin, Adelaide and Mount Gambier, and you can see that distance becomes a bit of an issue. So after I get back from here, the week after I get back, I'm going up to Darwin for a week. And that's the same distance as covering Belfast to Greece in terms of service that we provide. So in terms of how we think about providing service to patients, it actually provides a lot of unique challenges in terms of logistics and in terms of coordinating what you do. We provide outreach clinics also, as I said, to Mount Gambier, and we go down there at least once or twice a month and do a full day of clinic. It's a 65-minute flight away, 450 kilometres southeast of Adelaide. So we jump on the flight, see 50 patients, jump on a flight back to Adelaide, and it puts the whole sort of network reconfiguration in Northern Ireland and worrying about what happens to Altnagelvin and Craigavon slightly to shame. There are solutions to problems, and that's part of the interesting thing of seeing how a different system works and seeing what is acceptable and what standard of care can be provided for patients within a system that actually provides geographical challenges. There's a long-held preconception that Australian hospitals are not particularly interested in research, and unfortunately that's largely true, but there are pockets of excellence, and certainly in Melbourne you've got the Baker Institute, in Adelaide you've got ourselves, you've got Townsville from Vascular, you've got Ramon Varco in Sydney, Patrice Matapawi in Perth. So there are pockets of excellence in terms of vascular research, and the same holds true with all surgical specialties in terms of the research provision. And we currently have 5 PhD students active, 3 who are actively pursuing their projects and 2 at the stage of writing up. We also have postdoctorate students and master's students coming through our unit in a very active basic science and clinical research program, doing some pretty innovative and interesting stuff. We're also pretty actively involved in education and training, and again this is one of the strengths of our team, is that the team has a wish to try and pursue excellence in clinical care underpinned by research and education and training. And we take 2 trainees from the college SET programme, and I'll explain what that is in a minute. We run courses for teaching national trainees and also international delegates. So whenever I get back from here, we're running 2 courses back to back, taking candidates from Brazil, Colombia, Mexico, Singapore, China, the UK, and bringing them across to teach them some specialist techniques that we have at Flinders Medical Centre. So it's given an opportunity to actually establish a lot of these things within a system that encourages you to innovate and encourages you to be able to deliver the practice that you want. I mentioned SET, and that's the Surgical Education and Training Programme. And what was interesting was that I was involved with the Australasian College whenever I was president of ASiT around 2007. And the Australasian College introduced SET the year after Modernising Medical Careers was due to be introduced. And what they did was they watched what was happening in the UK, and they learned the lessons from it and adjusted things to take account of the mistakes that the UK had made. But essentially they now have a system which is very similar to what the UK wanted to introduce with Modernising Medical Careers. It applies to all of the surgical specialties and is 5 indicative years of surgical training. It is largely competency based, and it does involve a basic surgical sciences exam at the SET 1-2 level, and a fellowship exam which is generally taken in SET 4-5. In terms of the terminology that exists within Australian Hospital, again this changes slightly. We've got interns, which are PGY1s. You then have resident medical officers who are equivalent to our own senior house officers, which is the PGY2 to whenever they get a registrar job. They then talk about unaccredited and accredited registrars, and that really refers to working at registrar level, but being either on a college SET programme or not. So there is this parallel system where people still work as registrars whilst waiting to get into a college programme. And then there are the fellows, and this is a system that tends not to exist very well here in the UK, which are the post-training or overseas senior trainees who come across for more experience, and they generally provide a bridge between the training registrars and the consultants. So it gives the fellow an opportunity to act very much as a consultant does here in the early stages. But even within consultants, there's different terminology that exists. There are staff specialists and visiting medical officers. And the distinction between these two is really quite important. So at Flinders Medical Centre, we are 5 staff specialists. So we're predominantly employed by the public sector to work in the public sector. You are also allowed to work up to a day a week in private practice within the contract, and that's perfectly allowed. But visiting medical officers are paid really as a sessional rate, and their main obligation is actually their private practice. So they flit in for periods where they work in the public sector, and then they disappear for a period of time. And what's important to realise is that these people are often uncontactable for a large portion of time because they're off doing something in private. And so they're often unavailable should something happen. And unfortunately, a large number of Australian institutions predominantly have a VMO setup. So you can see very clearly that once you're in post as a fellow, that actually the responsibility on you for running the practice becomes a lot greater because the consultants are just not about quite as much as what they are here. And that varies from state to state, and certainly the eastern states of Queensland, Victoria and New South Wales, that would tend to be the predominant method of working. South Australia and Western Australia and Northern Territory are very much more leaning towards staff specialists, but it varies from unit to unit. With regards to the Surgical Education and Training Programme, they select any year from PGY2+. So after you've done your first PGY2 year, you can, strictly speaking, apply for a SET programme. The reality is that most specialties require you to have completed at least 12 months within that chosen specialty. And they also require you to have done some general surgery and some critical care, but they do count your time spent as an intern there as part of that time towards the selection. The basic science exam is equivalent to the MRCS here in the UK, and unfortunately it does have to be passed prior to SET 2 for the majority of specialties. In fact, we've suffered this coming academic year because the trainee that was due to come to us didn't complete his exam within his first 2 years of training and has been removed from the programme. And in fact, Vascular is now moving to a system whereby it is now compulsory to complete this examination before selection into the specialty as part of the college assessment process. Then you come to the fellowship examination, and this is a competency-based entry thing. So you can sit the examination whenever you feel that you're ready for it, and providing you're signed off by your supervisors. What is interesting, and I didn't actually realise that until this year, is that when the Australian trainees are signed off to enter the examination, that they're felt to have achieved all of the competencies required from their training programme. Therefore, they do not any longer require to be in a training programme. So as soon as they register to enter the exam, the college discards them and is no longer under any obligation to provide them with a training post. And if you think about what happens here in the UK with the fellowship exams, people sit their fellowship exams anytime within the last 3 years of training, so it might change thinking if that was to change here as well. What is interesting though is that if you don't get your exam, you cannot get specialist registration, and you can't work as a consultant without passing the fellowship examination. So it's a fairly high gamble if you do want to decide to sit the exam before your final year. With regards to the training jobs, the majority are a straight 1 in 3 to 1 in 4 on call. And in fact, 1 in 2 rosters are not uncommon, particularly in the smaller specialties. There are certain provisions given within how the salaries are made up to try and prevent people from being overtired, but the reality is that people do work hard. They work a large number of on-call during the training period. And this, as I said, is one of those advantages that potentially comes from working in Australia, is that it gives you that opportunity to gain more hours experience and more hours exposure for your future practice. Depending on the specialty or the training programme, it can be either a national or a state-based training system. And for the larger specialties such as general surgery and trauma and orthopaedics, it is largely state-based because there's enough volume and enough variety within an individual state to provide adequate exposure. For a smaller specialty such as ENT, vascular, it's a national training programme. And whenever we say national, that does also include New Zealand. So trainees are expected to move to wherever they're sent, anywhere within Australia or New Zealand. And certainly with regards to vascular, you cannot spend any more than 1 year in any unit during your training period. You must move between states at least once. And although the systems are allocated in a preference system, they tend to be allocated to the senior trainees first. And it's not uncommon for trainees to move at least 3 times during their training period. So that has not insignificant implications in terms of the cost, in terms of your family life, and the complete disruption. And seeing our trainees come through in Australia, they really do get it quite tough being away from their support networks at times, and that does provide challenges in terms of how they cope and how you have to manage the individual trainees within your unit as well. One of the benefits of having fewer trainees per unit is that you get greater exposure to procedures per trainee. There are also certain states where there is no public outpatient service, so actually trainees do not do any outpatients in New South Wales or Victoria. That just seems crazy as a concept, because how do you learn how to manage these patients? It seems ideal and idyllic as a senior surgical trainee to be going, excellent, no outpatient clinics, brilliant. But as you become more senior, you realise that actually outpatients is where you manage the majority of your patients, and it becomes quite an important decision-making part. But equally, it gives you that time to focus purely on the technical skills and the managerial skills that you require for running a ward. As I said before, there's less consultant presence on the wards, and the fellow has an increased responsibility of truly acting as that interface between the registrar and consultants, and essentially is working almost like a junior consultant would here in the UK. The administrative tasks are slightly higher as well, so you will be required to do a little bit more of the background paperwork that would normally come that the consultants would otherwise do. I see CJ nodding up there as well. So with regards to my own training in South Australia and what I've got out of my time as a trainee in South Australia, I had a good mix of open and endovascular surgery, which was something that I wasn't getting a good mix of here. I worked with surgeons who had dedicated endovascular lists, which unfortunately doesn't really exist in the UK at the minute. So that was one of the key things that I wanted to get out of my time in South Australia. I worked a 1 in 3 on call, but there was a strong culture of training support, and the work hard, play hard sort of ethos certainly held true where I worked. I decided to compare my logbook from my 2 years in vascular posts here in Northern Ireland with my 2 years in South Australia. And what was interesting to note is that whenever I looked at my open or standard sort of core vascular procedures, that actually I was doing reasonably similar numbers in Australia compared to what I was doing here, but there was a predominant shift to me performing the procedures as opposed to assisting at the procedures. The numbers were slightly greater for some of the key areas that I wanted to get exposure into in EVAR and infrainguinal bypasses and carotids. But the numbers were by and large the same for that component. What was interesting though was that in the area that I wanted to expand, my numbers were very, very different. So I was adding in a whole new facet to my job that didn't exist while I was here in the UK, as well as maintaining my logbook numbers in all of my open stuff. So what that allowed me to do, it allowed me to consolidate what I had been doing here in the UK, build upon that in terms of performing more of the surgery independently, but also learn these new skills that I took on board. My endovascular training was delivered largely by surgeons as opposed to interventional radiologists, and there was some valuable input from the interventional radiologists and radiographers. We had our own surgeon-specific lists, so we had control over our own practice, and that largely exists in the majority of places in Australia where people still have significant control over what goes on their list. You have the ability as the fellow to pick and choose what is on lists and decide what list you go to and to construct lists that fit with your needs. And you have an opportunity to indulge yourself a little bit with what your training requirements are. And it does, my own experience in vascular surgery was that it gave me an opportunity to still do a significant number of bypasses, but choosing the right treatment for the right patient and with a bit more clarity than what I was getting to do here. And the Australasians are slightly ahead of where we are and here in the UK from a vascular point of view with a conjoint committee which really looks to establish some ground rules for provision of training and education, exposure and opportunities. And there are some interface committees certainly with regards to the likes of hand surgery and facial surgery here in the UK, but they don't quite have the teeth that the Australasian conjoint committees have, which really then decree minimum numbers for procedures. They're not about accrediting or credentialing, but they are about providing support for education and training in these areas. So through the course of my 2 years in Australia, I was actually able to achieve all of the requirements required of me by the Australasian Conjoint Committee to be able to do this aspect of surgery which I'd had no exposure to before I went within a relatively short space of time. And once you get into surgical practice, and particularly anyone who's done any vascular surgery will see that my first arterial case as a consultant was completely different to what my first arterial case as a consultant would be here. It was performed entirely endovascularly, which is interesting given that no vascular surgeons in Belfast are performing any of this type of surgery. So it gives us an opportunity to manage patients in a completely different way.